Welcome to my presentation, Improving Preeclampsia Assessment. My name is Makenzie. With growing concern about risk of fetal and maternal mortality associated with diagnosis of preeclampsia, a care gap present in preeclampsia inpatient care was identified and addressed for the purpose of this project. The purpose of this project is to improve charting compliance of preeclampsia assessments in high-risk obstetrical patients. The importance of charting compliance is seen in patient outcomes. By improving access to vital preeclampsia assessments and educating staff about the importance of preeclampsia assessment, patient outcomes can be altered. In the proposed scholarly project titled Improving Preeclampsia Assessment Documentation for the Inpatient Obstetric Patient, a qualitative exploratory design through retrospective chart review was utilized to assess compliance with preeclampsia charting guidelines. Outcomes of the retrospective EMR evaluation of the use of an implemented preeclampsia flowsheet saw a 75% increase in charting compliance with the use of the flowsheet. With a confidence interval of 95%, the midpoint falls within upper and lower limits, meaning 95% of the time with confidence. By using the new charting flowsheet, there will be an increase in charting compliance of preeclampsia assessments. The outcome of this study showed an improvement in compliance to charting preeclampsia assessments after utilizing a centralized flowsheet in the patient's EMR. Throughout the course of the project, barriers, limitations, facilitators, and strengths were identified. The topics of further implementation, practice changes, further research, and recommendations were discussed within my manuscript. Preeclampsia is a leading cause of morbidity and mortality in expectant mothers and an essential topic for patients and clinicians. Preeclampsia and eclampsia rank second in the world for morbidity and mortality in women. According to the American College of Obstetrics and Gynecology, preeclampsia typically affects women from 20 weeks to 6 weeks postpartum. It complicates 2 to 8% of pregnancies globally, while costing the United States billions of dollars yearly. The hypertensive disorder can have a significant impact on maternal and fetal health. There is an increased risk for long-term hypertension, cardiovascular mortality, and stroke for the mother. For the fetus, there is an increased risk for uterine growth restriction, preterm birth, oligohydramnios, placental abruption, fetal distress, and fetal death in utero. We see many patients with hypertensive disorders ranging from chronic hypertension to eclampsia in my current practice. Evidence-based practice continually urges for appropriate and timely management of hypertensive disorders. Through experience and review of literature, I identified an area of practice that I believe could be improved. ACOG outlines physical assessments that should be done regularly for preeclamptic patients. These assessments can be charted in multiple areas of the electronic medical record. There is no systematic way to chart each finding or to view overall clinical progression of a patient's illness. Concern for not meeting recommended charting compliance as well as missing opportunities to catch worsening illness sooner encouraged my class to implement a centralized flowsheet. My scholarly project aimed to identify gaps in assessment charting for patients with preeclampsia and eclampsia and improve charting compliance according to hospital policies. Charting for a patient with preeclampsia and eclampsia is vital in the progression of the patient's disease progress and requires focused assessments to be completed in regular intervals. By creating a flowsheet where the recommended focused assessments are charted within the EMR, I hope there would be an improvement, not only an improvement in compliant charts, but essentially an improvement in identifying patients with a worsening illness. The components of my flowsheet are deep tendon reflexes, clonus, edema, level of consciousness, headache, vision, and right upper quadrant pain. In this quality improvement project, a retrospective chart review was done. The first review took place before the implementation of the new intervention. It looked at the number of patients in which focused assessment charting for preeclampsia was compliant per hospital policy. After implementation of the new streamlined flowsheet, a chart review identified the number of charts that were compliant in charting regular preeclampsia-focused assessments. With implementation of the preeclampsia assessment flowsheet, focused assessments were charted on regularly in accordance with hospital policies, improving charting compliance and enhancing patient and provider awareness of the clinical status. My area of concern focused explicitly on charting compliance for obstetric preeclamptic patients. Research showed that early identification of preeclampsia and improving the knowledge of both clinicians and patients could help overall outcomes in both mothers and babies. In the most current recommendation, the U.S. Preventative Services Task Force emphasized using a screening tool for the early identification of worsening preeclampsia. This recommendation was made due to continuously growing research on the topic that shows that early identification can have substantial benefits for both mother and fetus. A streamlined assessment flowsheet would provide benefits on many levels. The early detection of worsening clinical prognosis allowed for heightened awareness in both the patient and clinicians. This increased awareness allowed for further patient and clinician education focused on preeclampsia. There was an opportunity to improve patient education and implement best practice recommendations to improve the care provided by healthcare providers. By providing a streamlined flowsheet for the assessment of preeclamptic patients, clinicians can help reduce the risks associated with a diagnosis of preeclampsia, including intrauterine growth restriction, preterm birth, oligohydramnios, placental abruption, fetal distress, and fetal death in utero. If an effective tool is implemented on a much larger scale, there is the potential to lessen preeclampsia's economic burden on the healthcare system, with the cost of preeclampsia and its complications equating to $2.18 billion in the year of 2012. It is evident that preeclampsia has an immense impact on the healthcare system and its patients. By implementing an evidence-based flowsheet, the effect of identifying worsening preeclampsia promptly will result in benefits for many populations. Preeclampsia is a complication of pregnancy that can cause adverse outcomes for both the mother and the fetus. Preeclampsia presents itself as elevated blood pressures and proteinuria at any point in pregnancy. A complicated disease, preeclampsia can go unnoticed in some mothers, while others notice symptoms immediately. If left untreated, preeclampsia can be fatal to both the mother and fetus. Due to changes of identifying worsening preeclampsia status, it is recommended that the healthcare team consider patient risk factors, signs, symptoms, and biochemical markers for changes in decision-making during the plan of care. This project is governed by the following PICO question. In the obstetric patient, does the use of an improved preeclampsia-focused assessment flowsheet compared to the currently implemented process improve charting compliance according to hospital policy? This project aimed to identify patients at risk for worsening preeclampsia as well as improve charting compliance according to hospital policy. A systematic literature review on preeclampsia was conducted using online databases provided through Maryville University Services. The databases used included CINAHL Ultimate, Cochrane Database, and Systematic Reviews, and Medline. Keywords utilized in the search included preeclampsia, screening risk factors, treatment, and interventions. By using Boolean operators the search was narrowed down from many articles to include more focused results, and even further focused results were found by searching specific years. There were 3 themes identified in the literature review. Preeclampsia guidelines. The 2020 bulletin published by ACOG defines preeclampsia as a new onset hypertension occurring more often after 20 weeks gestation. The diagnostic criteria for preeclampsia include hypertensive blood pressure, proteinuria, or in the absence of proteinuria, other significant signs of preeclampsia, such as thrombocytopenia or impaired liver function. Preeclamptic blood pressure is a blood pressure of greater than or equal to 140/90 on 2 occasions at least 4 hours apart, or blood pressures of greater than or equal to 160/110. If the patient meets the blood pressure guidelines, they will be screened for proteinuria. Protein in the urine can be measured in different ways, including a 24-hour urine collection, a urine protein creatinine ratio, or a urine dipstick. Positive proteinuria is represented by a protein of 300 milligrams or more on a 24-hour urine collection, 0.3 mg per deciliter on a urine protein creatinine ratio, or 2+ proteins on a urine dipstick. In some cases, a patient may present with preeclamptic blood pressures and have an absence of proteinuria. Hypertension with thrombocytopenia, renal insufficiency, impaired liver function, Pulmonary edema or a new onset headache is criteria for preeclampsia diagnosis in the absence of proteinuria. Preeclampsia outcomes. For the fetus, antenatal risks associated with preeclampsia include IUGR, preterm birth, low amniotic fluid volume, placental abruption, fetal distress, and even fetal death. These antenatal complications have lasting effects on the health of the offspring, including an increased risk for hypertension and cardiovascular complications. Fox and colleagues in a 2019 article evaluated a 20-year follow-up cohort study of 2,868 young adults born to mothers with preeclampsia. The study showed that these young adults were 30% more likely to develop hypertension later in life. The findings in the study support that preeclampsia can have long-term effects on the health of the fetus. Long-term health effects on the mother also include increased risk for hypertension and kidney disease. Preeclampsia management. The effective management of preeclampsia occurs with the coordination of an interdisciplinary team that includes the patient by implementing an effective screening method for early identification of preeclampsia. The important task of patient education can begin earlier in the disease process. Patient education is vital during the many stages of preeclampsia management. By improving patient knowledge of the disease management, early identification of preeclampsia is much more attainable. Each of the studies were carefully selected to include strong primary sources. This is viewed as a strength. Each include the most up-to-date research with dating that does not include anything earlier than the year of 2015. Each of the literature included peer-reviewed information from approved journals and sites. The ACOG Practice Bulletin is the resource most used for referencing evidence-based practice in the clinical setting. Paired with information provided in two up-to-date resources, clinicians can be familiar with preeclampsia guidelines, outcomes, and expected treatments. Preeclampsia outcomes is an important topic when discussing the importance of recognizing the disease earlier. Each article of the literature compiled for this review outlined the serious complications associated with preeclampsia, specifically the long-term health of the mother, including the effects of cardiovascular and renal systems, are discussed in four of the reviews, and the consequences suffered by the fetus of a preeclamptic mother were assessed in 3 of the cited references. Overall, the literature review provides a consistent consensus by proving objectivity and credibility. The provided research shows that independent researchers have been able to arrive at similar conclusions about the dangers of preeclampsia. Each study independently collected and appropriately interpreted results. Utilizing multiple sources, each study was able to build credibility by showing linear data collection across years of research. A major weakness found when assessing literature on preeclampsia is the presence of homogeneity. Homogeneity is defined as the presence of the same or similar variables within research. Research has proven that you cannot generalize a patient with preeclampsia. It can develop in someone least expected and never develop in a mother with every known risk factor. Another weakness is that the study tends to focus on different aspects of preeclampsia, making the types of data collected different. There is no constancy between the studies as they use their own questionnaires, datasets, and populations. There were some limitations noticed when compiling literature for the review, the biggest limitation being that maternal fetal health is a protected population within research. This provided some difficulty when attempting to find recent articles assessing for the effects of preeclampsia on pregnancy. Simply being said, researchers will not knowingly put a woman and her unborn child in harm's way, as the benefit does not seem to outweigh the risk in this case. Data collected about the potential harm that preeclampsia can cause is based off of centuries of information gathered rather than current clinical trials. Luckily, we can better assess the long-term effects of preeclampsia and the effects on the mother and fetus in much later years. With this comes another limitation, as many of these studies follow the fetus through infancy and into adolescence. This means that these studies that followed each patient may just now be able to gather the data needed to assess whether there is true long-term consequences suffered. This focus of the literature review was to examine relevant research that supports the early identification and management of preeclampsia in the inpatient setting. The importance of implementing an effective assessment tool is seen through the literature reviewed, yet there is not a single study that examines the implementation of a preeclampsia screening tool within the electronic healthcare record. Identifying this gap in literature is what inspired the project's aim to implement a tool within the electronic healthcare record to aid in the documentation of preeclamptic assessment findings. The following are definitions of terminology used within the manuscript for those unfamiliar with preeclampsia. Preeclampsia is the new onset hypertension of proteinuria, or new onset hypertension and significant end organ dysfunction with or without the presence of protein in the urine. Typical onset is after 20 weeks gestation. Eclampsia is the occurrence of grand mal seizures in a patient with preeclampsia. Proteinuria is the presence of protein in the urine. Diagnostic criteria specific to preeclampsia. Intrauterine growth restriction is the restriction of fetal growth in utero. This is usually caused by diseases affecting the placenta, such as preeclampsia. Oligohydramnios is low amniotic fluid volume. Placental abruption is a condition where the placenta detaches from the uterine wall. This can cause serious fetal and maternal consequences, including death. Magnesium sulfate is a medication used to treat preeclampsia. A theoretical framework that fits well with this phenomenon of interest is a nursing theory by Myra Estern Levine. Her nursing theory termed the conservation model focuses on 3 principles. These principles include conservation of energy, conservation of structural integrity, and conservation of personal integrity. According to Levine, the wholeness of a person is dependent on these conservations working together in an ever-changing interaction. Levine theorized that a person would seek help when they are no longer able to adapt and conserve. In this case, healthcare is consistently working to ensure this wholeness. By developing a flow sheet for the documentation of preeclamptic assessments, we will identify patients from worsening preeclampsia before more severe complications occur, which could result in death of the mother or baby. The assessment tool will follow the principles discussed by Levine. This project focuses on maintaining the health of a person through nursing by ensuring the personal, social, and structural integrity. This will be done through the patient's interactions, adjusting environments, and advocating for the conservation of patients' health. Preeclampsia, a well-researched topic, is a health concern that is not completely understood. By implementing an improved preeclampsia assessment flow sheet, a gap in charting compliance as well as the identification of worsening preeclampsia was closed. The methodology of this research was of qualitative exploratory design. This research question posed concerns that have not been previously thoroughly researched as documented through a review of literature. Through a retrospective chart review, data was collected on the number of compliant preeclamptic assessments, pre-implementation, and then again post-implementation of the approved flow sheet. A budget factored in costs focused on utilization of supplies such as paper, pens, printer ink, and other supply charges. The budget included cost of conference rooms, snacks, and engagement prizes for encouraging staff participation. A large part of the budget was the gas needed to commute to meetings, staff trainings, and research days on hospital campus. A 35-minute commute and high gas prices boosted the gas budget to the highest number. This study was completed in a Level 1 trauma center at a large regional medical center. This hospital is a non-profit organization that takes pride in caring for some of the sickest patients in the Central Valley. This project focused on preeclamptic and eclamptic patients requiring inpatient care. Inclusion criteria included the patient must be over the age of 18 and younger than 41, the patient must be pregnant or recently delivered, and the patient must have the ICD-10 code diagnosis of preeclampsia or eclampsia. Data collection was completed by a separate data analyst team. The data analyst team retrieved charts meeting the criteria mentioned in the previous slide during a 3-month period. These charts were then assessed for preeclampsia assessment charting compliance, specifically the 7 vital signs I mentioned earlier in the presentation. A month of education and implementation of the flowsheet was completed, and then 3 months of charts were evaluated after implementation of the flowsheet. There were no physical, psychological, social, economic, or legal risks that resulted from this project. The biggest potential risk was a breach in confidentiality. However, this risk was minimal, and it was ensured that all potential patient identifiers were removed from the collected data. A quantitative exploratory design through a retrospective chart review was utilized for this project. Participants of the study were not engaged, and the patient information was abstracted from the data. Data collection occurred utilizing a data collection tool by data analysts formed for the purpose of this project. The abstracted data included the minimum information needed to accomplish the goals of the project, and patient information was not included in the project. The quality improvement study worked to improve charting compliance in the hospital setting for patients with preeclampsia or eclampsia. When considering an appropriate sample size, it was determined by a statistician that roughly 110, but no less than 100 charts would need to be reviewed, and approximately half of those charts would need to be before implementation, and the other half post-implementation. The sample size was chosen to attempt to accurately represent the true outcome of the flowsheet implementation. The purpose of this project was to evaluate charting compliance for patients with preeclampsia. A flowsheet with 7 variables of preeclampsia was implemented in February of 2023, and then charting compliance was assessed. 56 charts were assessed for compliance after implementation and 52 pre-implementation. By using the z-test of 2 proportions, it was determined that charts of patients with preeclampsia evaluated after implementation of the flowsheet had statistically significant improvements in compliance of charting. Our demographic data included females with preeclampsia or eclampsia diagnosis codes. 52 were selected to be pre-intervention, and 56 were randomly selected charts post-intervention. Outcomes of the retrospective EMR evaluation of the use of an implemented preeclampsia flowsheet saw a 75% increase in charting compliance with the use of the flowsheet. To visualize this improvement on this next slide, I do have a figure that shows that charting compliance before and after implementation of the flowsheet. With a confidence interval of 95%, the midpoint falls within the upper and lower limits, meaning 95% of the time with confidence. By using the new charting flowsheet, there will be an increase in charting compliance of preeclamptic assessments. Since the p-value is less than 0.05, the data supports rejecting the null hypothesis, which means using the flowsheet has improved charting compliance. With this finding, one could support using the flowsheet to meet charting guidelines to help reduce the risk of preeclampsia by identifying worsening signs and symptoms. The outcome of this study shows an improvement in compliance to charting preeclamptic assessments after utilizing a centralized flowsheet. During this project, the primary investigator did not experience unexpected problems, failures, or costs with the before-mentioned intervention. While gathering data for the retrospective chart review, it became evident that staff-to-patient ratios seemed to affect the nurse's ability to chart successfully. This concern from staff to primary investigator can be seen as an unintended benefit for the sake of improvement in staff-to-patient ratios. A barrier to this project was the implementation across 3 different departments. Data was collected through the patient's entire hospitalization, which meant that the patient could have potentially traveled through 3 units during their stay. This outreach to units proved to be a difficulty, and there is concern that essentially 1 unit may have had more reminders and encouragement to use said intervention. Like most barriers in research, this could also be viewed as a benefit to the project, as its intervention is valid and reliable, as it upheld charting compliance throughout 3 units. Preeclampsia continues to be a worldwide concern that carries risk for morbidity and mortality to the mother and fetus. The preeclampsia flowsheet, created utilizing evidence-based practice guidelines, offered a standard of care for preeclamptic charting. In summary, the purpose of this is to improve charting compliance of important assessments for inpatient preeclamptic patients. The intervention was a centralized flowsheet. The data focused on whether charting was compliant or not compliant. Our sample population was collected between November 2022 to January 2023, and then again March 2023 to May 2023. Our statistical evaluation utilized the z-test for the difference of two proportions, and our results showed that there was a 75% improvement in charting compliance, and with 95% of the time with confidence by using the new charting flow sheet, there will be an increase in charting compliance of preeclamptic assessments. And here are my references.